Greetings from Chicago, the new Western Front for Yoga Moves MS. I do want to, well, it's a pleasure to be here, and I do want to thank Mindy and her Yoga Moves MS crew for putting together this wonderful presentation. Thrilled to see how many people are attending from not just across the US, but even over the pond in Europe as well. So a lovely gathering. Thank you all for being here today. Our next speaker is Dr. Rany Abu Rashad. He has been a very, very good friend to Yoga Moves MS, and we are honored to have him here as our speaker. He serves as the Chief of Neurology and Director of the Multiple Sclerosis Center at the Memorial Institute for Neurosciences and MS. He holds a clinical faculty position at Central Michigan University. He serves as the Medical Director for Specialty Care at Memorial Hospital. His clinic there is designated as a comprehensive center for multiple sclerosis care by the National MS Society. He has lectured extensively on various aspects of multiple sclerosis, both nationally and internationally. He has had numerous publications and abstracts regarding multiple sclerosis, progressive multifocal leukoencephalopathy, as well as other autoimmune disorders of the central nervous system. His research team is currently focused on the role of blood biomarkers as a measure of predictive change in multiple sclerosis. He was the first in the United States to use neurofilament light chain as well as other markers in trying to measure patient function with MS. He has served as principal investigator in numerous clinical trials to help advance the care of MS patients. He has received numerous awards, including the Richard Alper Memorial Award, the Michigan Medical Grant, as well as, and most importantly, the Yoga Moves MS Leadership Award, as well as many others. So Rainey, we are truly honored to have you here, and the virtual podium is yours.
Thank you so much, Dr. Boski, and good afternoon, everybody. It's great to know that so many of you log into this. And number one, it is a sad day for me to see Dr. Bochi in Chicago. He was a staple here in Michigan for many years, and
don't make us cry.
Hey, such an absolute pleasure to work with. So it would be understated if I didn't give him, give him all the credit, because he truly has been an outstanding advocate for patients and really for Yoga Moves MS, as well as just empowering MS patients as a whole. So thank you, James. Great to see you. Second, to Mindy, obviously, you know what you're doing, and you've done a remarkable job of kind of building this virtual as well as real life network of MS patients. my patients, many of my patients see you regularly and are so excited to, at what you're able to offer them. And yes, to all those of you texting me and in my chat room, yes, go green. I see you all see the Sparty helmets behind me. So yes, go green. But the game's not for a little while. But with that, I would love to kind of give you guys an update on what we've been working on. COVID's been a quiet time for us on purpose. And I would love to kind of get you up to speed on some very cool aspects of our research. And so many of you did not come to this talk last year. I think a lot of people are new on this. And so I want to set the stage for you into what we do and what our focus is. And kind of what we've been trying to answer from a question standpoint in multiple sclerosis. So let's kind of break down MS in a very simplified way, and I think it'll help you understand what it is that I'm trying to accomplish. And so the way I described, someone says, do I have a video feed? Is my video not working, Mindy? It shows me that it's working.
I see you. Who doesn't see you?
I don't know, somebody in the chat just said, do I have a video feed? I promise I'm here. So some people—
I see you. Okay. I see you.
Okay, fair enough.
I hope everybody else does.
I hope you guys can see me. Okay, so let's kind of set the stage. So let's talk about multiple sclerosis first, and then we'll kind of build upon what we're going to do. So if I cut my arm with a knife and I put dirt into that wound, it's going to get infected, right? So what happens to the body when you get infected? Everyone try to focus and follow me on this pathway. It'll help you understand it. So when that infection occurs in my arm, I have a group of cells called the innate immune cells. These cells are made up of a combination of cells that are constantly surveilling our bodies. They look at the liver, the kidneys, the lungs. They look for anything foreign that is not something that is part of your body. They come to my arm where that dirt is. They attack that bacteria, and 95% of the time, those cells, those security guard cells, can destroy that bacteria, okay? 5% of the time, they are attacking that bacteria and they become overwhelmed by that bacteria, okay? The bacteria starts to replicate very rapidly, and all of a sudden that arm that was just a little cut before is now red and angry and ugly, all right? Maybe you're developing a little fever at this point. You're starting to see kind of an infection form around that area. So those security guard cells call your B cells and T cells, which are the cells located predominantly in your lymphocytes as well as in your gut tissue. And those cells are like our greatest fighters. And those cells jump into the bloodstream, they come to my arm, they clean up that bacteria, they take a picture of the bacteria, so now you have immunity to it, or if you're ever exposed to it again, those cells can immediately come out and kill it. So that would be a normal simplified immune process. So in multiple sclerosis, we always talk about demyelination. And what that means is the security guards are doing their normal surveillance. They come to the brain, they see the covering of the brain, myelin, there's a protein on that myelin that looks foreign to them for whatever reason. They attack it, they can't destroy it. They call T cells and B cells, and these cells come into your brain, attack your optic nerve, you get optic neuritis, they cause inflammation, you get optic neuritis and vision loss, and now you have multiple sclerosis. And then they leave and they take a picture of your myelin saying that this person has MS, okay? So let's focus on what happens when they're attacking that myelin. When the B cells and T cells come into the brain, we always talk about this disease as a demyelinating process. So we talk about myelin all the time, right? And for a long time, and it is true that MS is a predominantly demyelinating disease. But I want to take it a step further for you to understand contextually kind of what else occurs in the brain, in the central compartment of the brain and spinal cord, when you're talking about multiple sclerosis, okay? So as those cells come in, yes, myelin is destroyed. So myelinated fibers are what we call white matter fibers, okay? However, white matter fibers are not, and they're called white because the myelin looks white when it insulates the nerve. So in our brain, we have white matter fibers, which is myelinated, and gray matter fibers, which is unmyelinated, okay? MS is predominantly a disease of white matter, but there is gray matter involvement as well, okay? So it's not just the white matter that's being involved. So what's happening in MS is you have an inflammation of the myelin, and you have damage to the myelin. In addition to that, you have a degradation of gray matter, which is kind of that slow atrophy that's occurring behind the scenes at all times in an MS patient. In addition to that, you have a variety of other cells, some of which are called microglial cells, some of which are called astrocytic cells, some of which are called oligodendrogliatic cells. These cells all are part of this process of demyelination, remyelination, and atrophy. So what does that mean to you? Right now, you're all confused. You're saying, what the heck is he talking about? Let's break it down. Many of you know that most of my research is in a protein called neurofilament light. And I talked about this last year, and I've done several interviews about this. However, this was really just the beginning of our research, and we've held back a lot of what we've been doing for a very long time for this reason. So neurofilament light is very exciting, and we have thousands and thousands of samples now that we've collected from our patients over the course of the last 3 years. And we thank all of you who are on this call who have allowed us to do this as part of our research protocol. You have no idea how helpful this is. However, we always knew that neurofilament light was going to be one piece of the puzzle, right? We understood that neurofilament light was just a marker of that white matter track. And it showed us kind of underneath that demyelination, underneath that area of damage, it gave us an idea of how much of the foundation of that nerve is damaged or not, right? The problem with that is that if I was to come up to one of you today and punch you in the head, I would never do that. But if I was to punch you in the head very hard, you might get a concussion, right? Well, your neurofilament light level would go up from that concussion. So if I measure a football player's neurofilament light levels, they would likely go up after a significant head trauma. If I'm in a car accident and I hit my head, it might go up. If I have a stroke and I have damage in my brain, it might go up. So neurofilament light was not specific enough for multiple sclerosis. So our focus in our research was not to look at just neurofilament light as the basis. So we used that as the beginning, and we knew we needed that because it is a piece to the puzzle. But what's been most exciting for us is really developing upon that. And now what we've worked on over the course of the last period of time here is something that we're calling a biomarker multiplex. And what this is, and I want you to understand this, is we are looking at neurofilament light levels, which are occurring in white matter predominantly. We are then looking at 3 other proteins on top of the neurofilament light. So we're not just looking at one protein. So one of those proteins is something called gliofibrillary acidic protein, or GFAP. One of them is a protein called chitinase 3-like protein. And the other one is a protein that we are developing. And the idea behind this is we want to look at every facet of your MS. So not just the inflammatory component, but the degenerative component, as well as the remyelinative component. So we want to know what different levels of nerve damage are occurring at different parts of the brain. And when we take all that information, when we're able to gather all that information, we end up with really 4 data points. Those 4 data points give us an indication at any one time as to whether your disease is being aggressively inflammatory, predominantly atrophic, where we're losing gray matter predominantly. And then we also get an idea of how much repair is occurring. And so then what we're doing is taking that data, we're developing a database with that data, and then that data is being articulated through artificial intelligence and analyzed through artificial intelligence to develop a ratio of how we can look at decisions in your MS care much earlier than before. So the idea behind this is we want to be able to, in the future, in addition to your normal MRI, which are very helpful, in addition to that, we'd like to draw your blood, develop a score similar to scores that we use for some of our heart issues like atrial fibrillation, even concussion scores. We want a score that in real time gives us an indication of which way your multiple sclerosis is moving, how effective your medication is there suboptimal response or is there not? And so if we're able to do this the way we think we're going to be able to, and this is very complicated to do, this is not simple. And the reason this is when you think about it, in this room, there's hundreds of participants. Some of you are young and have began your MS journey, unfortunately, over the course of the last several years. And so you are in the state where physically, for the most part, you are functioning. If somebody on the outside looked at you, you would walk normal, you would talk normal. Cognitively, you're likely intact. You may have bad days, no question about it. You'll have days where your fatigue is profound. You'll have days where you feel less sharp. If you have an infection, you definitely feel symptoms, and I'm sure you have some tingling. That patient structurally is very different than the patient who's 62 years old, who's had this disease now for 25 or 30 years. That patient has noticed that I am just getting worse. So I saw a patient this week and I said, have you had any relapses or any new symptoms since I last saw you? And the answer was no, everything's been steady. And I said, okay, so you're doing pretty well, you're pretty stable. She said, no, I can't walk up the stairs as well as I was 6 months ago. So she essentially is giving me insight into this slow deteriorative progression. So for her, what that means is that her left-sided foot drop, which has been there for 15 years, is slightly worsened to the point where when she goes up the stairs, it might take her an extra 25 seconds. That slow degradation that patient is having is very different than the patient who has very aggressive, to the patient who has a new optic neuritis that resolves almost entirely within the course of 4 to 6 weeks. And so when you look at a disease like MS, a heterogeneous disease like MS, we need to get better at answering where you are on the spectrum of this disease. And so in this room, all of us talk about MS and we're talking about one disease, but you have to understand that every one of you, I love that, 66 and still a badass Sandy. I like that, Adam. But the idea behind this is, can I draw your blood when you're 32? Can I make an adjustment because your blood changes and the protein makeup that's occurring microscopically in your brain changes at 39? And then can I adjust your medication at 47 because the protein concentration changes again? And then do I need to do it again at 55, for example? And so Joy asked a great question. Is this smoldering MS or progression in the absence of relapses? So a little bit of both. So smoldering, these are terms made up by men. So I want to start by saying that. When we talk about smoldering MS or progression in the absence of relapses, great ideas and great definition. But remember, none of that is, we don't understand those processes fully. We'd like to believe we do. We understand a lot about them, but we don't understand them fully. And so smoldering MS, or what she's talking about, is kind of that low grade. A lot of people think this is microglial in nature, where there's kind of this slow degradation occurring no matter what. So the cells come in, they attack, but they leave behind some bombs. And those bombs just sort of nip at your bud over the course of the next few years, and you slowly start to get worse. No, not go Purdue, Chris. So that becomes that smoldering MS where things are slowly deteriorating. Progression in the absence of relapses is really a fancier word for nothing brand new occurred, but I'm definitely getting worse. I'm definitely getting worse. So that patient walking up the stairs. So the answer to you, Joy, with that question is I want a blood test that looks at various proteins at different compartments of your central nervous system. And I want to be able to differentiate, is this progression in the absence of relapses? Is this inflammatory predominantly? Is this atrophic, or is this other? Is this some other central nervous system disorder that's occurring in real time? And so it's a thought that I think many of us have had in the clinic, and those of us who do this, at a very high level, seeing a lot of patients, really struggle sometimes with patients who we have on what we consider very significantly aggressive or high efficacy treatments who continue to deteriorate. And so the speaker after me, Dr. Bieber, knows exactly what I'm talking about. Is we'll have patients who are on high efficacy therapy. We immunologically think we're doing what we need to do. We're controlling the so-called cells that are causing their MS. And at the end of the day, we end up with no relapses, which is good, no significant MRI changes, which is good, but we end up with a patient who still hasn't found that quality of life that we want. And so we want to be able to answer that question, and we want to be able to kind of help patients make decisions from a medication standpoint much earlier, and can we get ahead of that progression? So that is our idea. That is where our research is at right now. And it's been very exciting to go through, very hard to do. I'm very tired, but we will get there, and all of us are tired. And it's not very easy, but we're blessed technologically with really some really cool tools from an ELISA standpoint now, using something called single molecule array, that we can now look at these microscopic proteins in a way that we couldn't before. And so what I would say to you as I wrap up, because my time is almost up, is two things. Number one is, do not lose hope. Those of you who are texting and talking about downhill, I understand. We see downhill. It breaks my heart every day. But we are working, many people around the country and world are working very hard to answer these questions. And I want you to remember something. MS, before 1993, we could do nothing. We literally could do very little, if anything. We would give some steroids on occasion, and we sort of watch people kind of march down. MS in 2021 has made leaps and bounds in terms of where we're at. We continue to work hard on remyelination. We continue to work hard at disease understanding and threshold modeling of treatment choices. And so what I would say to you is don't quit. Don't think that, and these things occur slow but rapid. And what I mean by that is it's not going to be tomorrow, but it could be within 3 to 4 years that we have more information on this and have some type of phase 2 trial theoretically that we're looking at in these types of things. And so so to all of you who have this disease, and many of my patients are texting me right now. You guys are blowing up my phone. I love you guys too. What I would say is you are part of a disease process where there's a small number of clinicians in the world who do this, but the ones who do this, I can tell you, they care about this particular disease in a way that I think is truly passionate. And so we will get to the answers, and hopefully, as everyone says, be unstoppable as it comes to this. And so I will stop there, Mindy, and you can shoot some questions if you'd like, and then I'm excited to introduce Brandon to you guys.
All right, let's see. All kinds of wonderful kudos to you. Thank you for working so hard and tirelessly to help us. Fascinating research. Keep up the good work. Question, is this blood test for patients prior to permanent disability?
Yeah, so we're checking patients between the age of 18 and up. We don't stop at age. We don't care what stage you theoretically are in your multiple sclerosis. So we have serum across the board. I think our oldest patient is 74, 75 years old now that we have data on.
Okay. How can you know if your symptoms are going to get worse?
So the correct answer is we never know if they're going to get worse. But if you're talking to a clinician who's done this for a long period of time, we have seen just about everything. Yes, your case is its own fingerprint, no question about it. But there are subtle signs of things that we can glean and really understand if our treatments are at least controlling the big parts of multiple sclerosis. And so I think the most important thing I would say is there's no way to tell you you're going to get worse or you're not. But what I would say to you is we need to make sure you're on the optimal and correct therapy in your particular case. And that's not a straightforward answer always. That's a conversational answer, but I think we've gotten quite good at getting people on drugs that are highly effective, at least for the most part. And in 5 years, it's going to be vastly different. I remember the first time I ever wrote a very, very high efficacy MS drug years ago, Lemtrada. I mean, the first case in Michigan might be on here somewhere, I'm sure. I still remember that day. It was 6 or 7 years ago. And I remember I didn't sleep for 2 nights after I gave that drug. And I was nervous and I didn't know what was going to happen. And now I look back now at 6 years and we kind of write that or other drugs, we become, so in 6 years, it's going to be a very different conversation again. And so just remember that we're making huge progress in this. I can't hear you, Mindy.
You give such hope to so many, and it's coming through in the chat. 2 more. How can we get this blood test and how do we get involved with your research?
So this is for our clinic patients. We are working on a mechanism to spread this out to other clinics around the country. It's not as simple as we wanted it to be because we have to resubmit our IRB for every place and add a subgroup, add a subgroup, add a subgroup. But there's been a lot of physicians around the country who've asked for this on individual cases, for example, and they just sort of want to know, if I have this weird case, can I kind of just see what it is? Obviously seeing us, you will have this done. Anyone who comes to us will have this done. It's part of we offer it to every MS, every new consult that we see and every follow-up that we see. But I think the age of understanding that it's still research-based is important. So many patients want to know their numbers and I will not give them to you. The FDA won't allow me to. I have to keep this information private because making treatment decisions based on a test that has not been fully validated is not allowed. And rightfully so, that's to protect you. And so we at least, at this stage, we have enough clinical trials with protein biomarking that we're able to kind of plug patients into certain ones when we need to.